Hello, and welcome to Truth in Dentistry with me, Dr. Paul Belzycki, where we fuse art with science to maintain healthy teeth and gums for a lifetime by employing evidence-based protocols with attention to detail. Today's presentation will deal with the employment of non-invasive therapies to control decay and periodontal problems in those individuals that present with unique obstacles to conventional therapies. Note that no one pays me to use the products that I mention, and I do not receive any sponsorship or remuneration for my efforts on YouTube. I do this solely for those like-minded dentists and hygienists that care deeply about their patients. My efforts will be obvious to those that do. My recommendations are based solely on what I have found to work successfully in my hands. By way of intraoral photographs of my cases, I hope to share my clinical experience with you and have you be the judge for yourself. This is a rather lengthy presentation given the importance of the topic, and it is geared for dentists and hygienists. So get yourself some popcorn, a beverage, and settle in. I firmly believe that the information is valuable. And here we go. This presentation will deal with non-invasive protocols for the control of periodontal disease and tooth decay. And two products will be focused on. One is Prevora, and that is a 10% chlorhexidine coating. This product is supplied by CHX Technologies. And the second product will be Silver Diammine Fluoride, and it is supplied by Oral Science here in Canada under the name Advantage Arrest. Also, there's a product called Revastar, similar product by SDI. Both chemical agents are antimicrobial. They cause the death of bacteria in the biofilm located on teeth and gums. It has been suggested that an alteration results in the biofilm to render it less pathogenic. However, the science is really out on that. Let's just say that they're broad-spectrum antimicrobial agents that kill everything, or at least reduce the amount of bacterial load that's on the teeth and gums. Now, there are two distinct methods for treating the progression of periodontal disease and tooth decay. One is invasive, and that's surgery, where flaps are raised and debris is identified and removed, and the site goes on to heal once it's closed. And then a second method is non-invasive, where inflammation is present, an antimicrobial agent is applied, and there's resolution of the tissue. The myth presupposes that if you choose one camp, you're somehow lacking skills or knowledge to function in the other camp. So for those of you thinking I'm biased one way towards the other, let me explain that I'm a GP that does periodontal surgery. Here I will be addressing three defects on the root surfaces. In the presence of a mucogingival problem, there's a minimal zone of attached gingiva. Teeth are prepared, restorations are placed, an amalgam in the molar, and two composite resin fillings in the bicuspids. And a flap was raised, connective tissue was harvested from the palate, it's sutured in place, and that went on to heal quite nicely after a few months, and then a crown was placed on tooth 36. So as you can see, I'm well versed in the surgical management of hard and soft tissue. Over the course of 45 years, I have successfully restored everything that one could encounter in dentistry. Let it be known that I do refer out implant placement and orthodontics. I am not comfortable in doing those. Surgery is underpinned by a mechanistic mindset that the disease process can be treated by mechanical means alone. So we raise a flap, we find debris on the roots, and we assume that's the cause of the disease. The debris is removed, and hopefully the disease process stops. Surgical protocols are immediately satisfying. I mean, going from here to here, you feel good inside. You can see it, it's visceral, it's tactile, and you assume that you've set up an environment where healing can occur. And lastly, there is the remuneration for these protocols. An adjunctive point of view was put forth by Dr. Walter Loesche, a dentist and researcher, PhD. Just to let you know, he's published 3 dental textbooks. He's published more than 170 peer-reviewed articles and 50 chapters. He served on the editorial boards of prominent scientific publications, including the Journal of Periodontal Research and the Journal of Oral Microbiology. So the man does know a thing or two. But back in the day, in the 70s, 60s and 70s, Walter was labeled a maverick in translational research in dentistry. Translational research is linking basic biological and scientific data to practical applications in the clinic or in industry. Guided by his extensive research, Walter's approach was to treat caries and periodontitis as bacterial infections. Particularly with periodontal disease was his use of antibiotics, both systemic and topical, to reduce the severity of the disease process. He claimed to have reduced the need for surgery by 50%. This, of course, ruffled some feathers with a majority of the clinicians entrenched to favor surgical protocols. As quoted from that paper, the instinct to protect orthodoxy is natural. Resistance to his approach may have been based on economical concerns of a drop of income if less surgery is mandated. And then, of course, there's also the lack of insurance coverage for innovative procedures that may also pose obstacles. Walter did have disputes with the periodontal orthodoxy at that time, despite the weight of evidence. And his studies have been replicated in other centers as well, particularly here in the University of Toronto. Personally, for myself, after 45 years of full-time practice, I highly value my surgical skills. So much so that I too seldom considered non-invasive therapies. Furthermore, I felt that those that advocated them were not confident with their own surgical skills. So I did have a bias. And that bias was suddenly changed in 2020 with a phone call from my sister, late one evening. I get a call, and she claims that a friend of hers has a 40-year-old daughter suffering from a form of muscular dystrophy that has resulted in muscle weakness and severe skeletal abnormalities. She's been confined to a wheelchair since birth, and there are other systemic issues at play. She was recently seen by a hospital-based oral surgeon for pain related to decaying third molars. She was informed that nothing could be done given the severity of her conditions and possible complications of treatment. So my sister asks me, "Paul, can you help?" And those of you that know me, and those of you that don't, let it be known, I usually jump in fairly quickly. So I tell my sister, give me their telephone number. I call and arrange to go and meet with the family that evening. And this is in the kitchen at their home. This is in the kitchen, our first meeting. And I will tell you that all her disabilities are physical. Cognitively, she's quite bright. She has a degree in journalism. She does have a tracheostomy in place, so speech is halting. Totally normal in terms of her mental capabilities. And I ask her to open her mouth. I peer inside, and there is the presence of an open bite. And I ask her for a little bit more opening, and I get about a millimeter or so, just a tiny bit. So I try to pry open the mouth a bit more with a plastic instrument of some sort, and it's no-go. So suddenly I realize that all my wonderful, valued surgical skills are not possible in this case, or they somehow must be altered. I claim that I'm not sure what I can do, but I'll try, because non-treatment in this case is unthinkable, given the discomfort that she has. So I work with dedicated, like-minded colleagues that are brilliant and very generous with their knowledge and time. I called Dr. Howie Tenenbaum, and he says he will arrange to meet with an oral surgeon who may be capable with the extractions of the decaying third molars. I am to initiate whatever oral hygiene might be possible given the limited opening. I am to employ Silver Diammine Fluoride and Prevora in the hopes of slowing down rates of decay and hopefully reducing the degree of gingival inflammation. I have no working knowledge of these modalities. I don't know what they are. I've heard of them, but I know I have homework to do. So I send an email to my colleague. He's Dr. Brian Darvell. He's a PhD in chemistry and works primarily in dental materials and has written textbooks. And I ask him, do you know anything about silver diammine fluoride? And yes, I do. And then he claims you should spell it with 2 M's. You only spelt it with 1. And it's not a difference between British English and English as spoken or written in the Americas. He claims there are two different entities. There's a difference between the two. We have a silver fluoride molecule that's unstable. It will dissociate in the bottle before you can apply it onto the patient. So it is mixed with ammonia. Ammonia is NH3. That's 3 hydrogens around 1 nitrogen. NH3 bonded to a coordination complex with a metal ion is termed an amine, and it's spelled with 2 M's. Amine with 1 M refers to a covalently bonded NH2 group, which is chemically distinct. So I know silver diammine fluoride is written mostly with 1 M. I'm going to use the correct spelling, which is 2. I make mention of it because otherwise I'll be taken to task by the typo police, which will start, and they'll start sending me comments. So if you want to argue the point, call Dr. Brian Darvell, and good luck to you. So he goes on to inform me that this solution penetrates into porous enamel and dentin. The solution is applied for several minutes. Over the course of some hours, metallic silver dissociates and accumulates in the microporosities of damaged enamel. And this is responsible for the dark staining that I will show you. This provides a constant source of free silver ions to bind with bacteria, causing the cell death, and thus decay process is arrested. Hence the name arrest. Silver is also implicated in inhibition of matrix metalloproteinases and thus may also slow collagen breakdown. Fluoride is not particularly antibacterial in these concentrations, but may cause some calcium phosphates or fluoroapatite crystals to form locally, thus improving resistance to acid attack. And Brian is the first one to tell you that you cannot restore or remineralize enamel to what it was before. Prevora is 10% chlorhexidine coating. Chlorhexidine is antimicrobial. Prevora is a licensed pharmaceutical preparation here in Canada that was initially developed to treat decay. However, clinicians noted an improvement in the periodontal status of the patients that they were working on. And this is due to a general reduction of the biofilm on both the teeth and the gums, or perhaps an alteration of the biofilm, rendering it less pathogenic. Chlorhexidine mouth rinse that we use, such as Paradex, have a concentration of approximately 0.18, and this is washed away fairly quickly within minutes. So chlorhexidine will linger with this preparation. Prevora comes in 2 bottles. Bottle 1 contains the chlorhexidine in an alcohol which quickly evaporates, leaving a whitish film. Case of mine, inflamed tissue, that's the film applied. The second bottle contains an organic resin of some formulation that is applied over the chlorhexidine to keep it in place for at least 1 to 2 days. It's very easy to apply. I use a micro brush from the bottle onto the tooth and gums, and as it evaporates, this whitish film forms. Instructions are given to not brush or use commercial mouthwashes during the first 24 hours. And patients love that. I mean, I don't have to brush or clean? No, just leave it alone and don't touch it, but you can eat normally. 3 applications are made 1 week apart, and then a 4th application 1 month later. And it can be reapplied on subsequent recall exams if the need is there. One of my tenets of healthcare is that every patient deserves treatment performed in an exacting manner. And now the challenge is how to fulfill this responsibility given the obstacles. And she claimed that she remained in her mobile chair for all past treatments provided to her at dental offices, that she just wheeled herself in, tried to situate somewhere, and people tried to work on her. So I asked her, do you sleep in a bed at night? And mother was there as well and says, well, of course she does. So I said, well, why can't you just pick her up and put her in my dental chair? Which was simple enough. We just had to move the dental chair so it was closer to the armamentarium. And here she is. Her body is pretty much fixed in that position. Her head can't turn at all. Everything's near fused. And it just so happens that she's just positioned perfectly for a right-handed dentist. Before me is a delicate human being, one who is in discomfort from dental pain due to decay. one who is silently suffering. She exemplifies the Latin word patior, and I hope I'm pronouncing that correctly. And from Wikipedia, this is bearing whatever suffering is necessary and tolerating stoically the interventions of the outside expert. And that is me. But before me is a patient, not a client. I don't like that term. In that position, I was able to gain access to the left buccal vestibule, and there you can see all the plaque that's on the teeth. She can't brush by herself, so her parents or the caregivers have to do that. And I was able to get in a rotary instrument to do a little bit of profing, and she claims that was the first time anybody had done that to her. This was our first small miracle. Something might be possible after all. I picked up a Cavitron and stopped immediately because, as you can see here, I've blown through some weakened enamel that was decalcified. I could also access the right side. This molar is in crossbite. It had occlusal decay. So I was able at a later date to get a rotary instrument in there, and I did place a restoration. But I could access the right and left buccal segments, but I couldn't probe or feel the tops of the teeth in the bicuspid and molar area because of the limited opening. After profing, cleaned it up. This was the first time I was using Silver Diammine Fluoride, and I asked a few folks what it's like, and they said, oh, it tastes terrible, don't get it on the tongue. Patients don't like it. You have to watch out for staining. It means stained clothes. So watch the YouTube videos, listen to some folks, but I know I have to use this by myself the first time to really get a feel for it. So I was quite tentative. I put some SDF here and on the molars and on the bicuspids for about a minute, and then washed it away with water and applied Prevora. So you can see the whitish film. This little bit of darkness on the gingiva bothered me because Dr. Darvell said it will stain soft tissue if there's an injury to the soft tissue of the soft tissue. So it was applied in a limited fashion in these areas. And then I washed it away, as I said, and applied Prevora. And I did the same thing on the other side. But before I did it, I noticed this rather large fibrous papilla. I applied the Silver Diammine Fluoride only in this area. Right here, I took a scalpel, and really without local, I just lopped off the papilla and applied the Prevora on that area. And this is how she came back a week later. And you can just pick up here that the papilla is greatly reduced, normal looking. And the gums were tighter and didn't bleed as much. Here you can see the dark staining of some surface decay, as well as in the posterior area. And thankfully, the staining of the tissue did go away. It did resolve. So now I felt a little bit more emboldened, and I placed the Silver Diammine Fluoride on the entire segment, and I left it there for 3 or 4 minutes. Didn't wash it away, and then covered it with Prevora. And this is how it came back on the second week. And now we can see far more pronounced staining, particularly in this area where there was a lot of demineralized enamel. And this one image, first time I'm using these products, blew me away. I thought, wow, that tightened up tremendously. In addition, for the first time, yes, we as dentists look at this and we say, oh, it's dark, it's unsightly, but nobody sees down here. And effectively, it is hoped that I have arrested the decay process rather than having to get in here and start cutting and putting composite resins all along the cervical margin is not an easy thing to do. So this single image reassured me that I was onto something good. Starting here and going to here, I knew that I was onto something. I pretty much, this image sold me on the use of Silver Diammine Fluoride in conjunction with Prevora. Preoperatively, and then the first week and the second week. How I clean her teeth, and how I usually clean teeth for patients where gingival problems are an issue, it's sore, maybe inflamed and delicate, is I will use this interproximal brush. They come in two sizes. This is the narrower one. And I'll use a Chlorhexidine mouth rinse, this time Oro Cleanse by Germafene. It has a 0.12% chlorhexidine. And I'll just go in between the roots of the teeth interproximally if I can get in, just like that. And often you just push through all the soft, mushy stuff that nobody's gotten to. They're not flossing, they're not cleaning adequately. You can even get bigger chunks of food out. So I think that this is just a very easy way of getting in there quickly and cleaning in between the teeth. And you can see here, it's difficult to get intraoral photographs of her, obviously, but you can see here that I'm forcing the brush in between the teeth with Chlorhexidine mouth rinse. So that little bit of bleeding is the past 15, 20 minutes I've been beating her up with that brush. So this dentition has remained stable for 2 years. SDF has indeed arrested the decay. Prevora has improved the periodontal status. And that area back there where I damaged the enamel is hard and solid. She did go on to have the third molar removed, and there was a first molar that was lingually inclined. How they got it out is beyond me, but they got it out. I also was able, after a while, learning how to maneuver in her mouth, I was able to get an occlusal buccal amalgam in this tooth coming horizontally. There was sufficient room. And just as a segue, those of you that have thrown out your amalgamator, I think you're doing your patients a disservice. Because in areas that are compromised, that are difficult to attain moisture control, if you don't have amalgam, composite resin just isn't going to fly. That's just a little aside, my plug for amalgam. This case motivated me to employ non-invasive protocols that have proven themselves to me to be most efficacious where nothing else seemed possible. And my goal is to maintain her smile so that she can engage the world with pride and self-confidence. And in this photograph, she did give me a little thumbs up, if you can see. So I thought, where else could I start using these modalities? And another class of patient where nothing else really seems possible are those patients undergoing cancer therapy. And this gentleman has been with me since I started practice 45 years ago. He's now dealing with multiple myeloma, and he will be taking infusions of zolduronic acid, or Zometa, which is a potent bisphosphonate, particularly if given IV. And it's implicated in MRONJ, which is medication-related osteonecrosis of the jaw, which can happen post-extraction if a tooth has to be removed, or if they get a bad infection, either endodontically or in combination with the perio. If there's an overriding issue and bone gets exposed, it can lead to MRONJ. He is on other therapies that result in xerostomia, which increases the progression of decay. This also results in complaints of root sensitivity. Also, there's a generalized mucositis throughout the oral cavity, often in combination with a candida infection. So this cohort of patient does suffer. And there you can see, in addition to all of that, he has some black hairy tongue. He was sent to my office for a reevaluation because it needed to address any possible dental problems that might lead to an infection or an extraction before starting on Zometa. And at the dental clinic, at the cancer center, they picked up a radiolucent area here and asked me to reassess it. And having records going back to 1986, I was short. I was short by a millimeter. My good endodontist colleague, Dr. Andrew Moncars, always says, "Paul, did you command the apex?" Well, here I didn't command it 1 millimeter. And sometimes it's not a problem. Sometimes it can come back to haunt you. So in 2017, it was bothering him. Here I raised a flap. I take these pictures all day long. Can show you I popped in a little amalgam restoration. And that went on to heal quite nicely. So there was a greater degree of radiolucency in 2017 as opposed to the current radiograph that I took in March of 2023. So I thought that was not a problem. He was not symptomatic, palpating the tissue, there felt nothing, so I thought we should just leave that alone. But I did notice on the radiograph surface decay that I might otherwise have missed. Knowing that he was suffering from xerostomia, you take a second look at your radiographs. So it's a little bit there and more pronounced in that area. So these crowns I put in 2009, 87. And cleaning in between the tissue with those interproximal brushes, I got a lot of bleeding. So with a micro brush, I applied the Silver Diammine Fluoride in between the teeth all along the gingival margin. Very easy to do. Just make sure you don't drop any on your close or on the cabinetry. It stains everything. And once it stains on the arborate, the only way to get it off is really to sand it off. It just penetrates so fine into every nook and cranny. And after that, I applied an overcoat of Prevora. So leave the Silver Diammine in place, lots of it for about 2, 3, 4 minutes, and then cover it with Prevora. Don't wash it off. And that's how it came back. So this is almost as a disclosing agent, showing you where the decay actually is. And I showed this to a colleague who claimed it's almost like using the 5-fluorouracil, which is some sort of cream for treating skin cancer, where you see a lesion on the skin, you apply what you think is just the one lesion, you apply that on the skin, they come back a few days or sometime later, and you can see other areas have been affected where cancer had spread but not seen visibly. So here, finely detailed is where surface decay is starting, interproximally on these teeth as well. Made a second application. In the fourth quadrant, tooth 44 had decay, was able to put an amalgam restoration. And again, Silver Diammine Fluoride in this area. I didn't put it on the hypocalcified or decalcified structure here. And he came back and arrested whatever surface decay is there. And he went on to state that his sensitivity is being reduced. And here you can see I'm cleaning in between the teeth and no bleeding. In the upper arch was the same story. In the first quadrant, I placed an amalgam restoration in a large cavity here. And again, amalgam does not suffer recurrent decay the way composite resin does. So if you've thrown out your amalgamator, patient's getting second-class service as far as I'm concerned. Silver Diammine Fluoride, Prevora, and that's how he came back. And again, you can pick up where all of the root decay is. So it happens quite quickly, quite fast. Made another application. So we did achieve a reduction in tooth sensitivity. We also suggested toothpaste containing sodium fluoride in a high concentration and calcium phosphate, such as Prevident. Also for dry mouth, I found that BioExtra, a product here in Ontario, they have a whole line of products for folks that have xerostomia. Also Xylomets to promote the flow of saliva rather than sugar mints, and to brush the tongue with baking soda and water, because the baking soda is very benign and it helps break up the substance that's forming his black hairy tongue. So before Prevora and SDF, I really had nothing to offer. All I could say is, geez, I'm sorry you have all of this. Try to use ice chips and keep your mouth moist, and here's a fluoride tray. And so often the compliance with that isn't wonderful. But in this case, being able to stop surface decay on a cancer patient, these are the folks that need it the most. This is another case, 55-year-old female with, unfortunately, recurrent breast cancer. Also, Onzometa. In her case, she was already on it. So I really did not want to do invasive surgery on any kind. of any kind. The other gentleman, I could have done something waiting to go on Zometa, but in this case, she's already been on it, and I haven't seen her in 10 years. At the dental clinic, she was seen and said, you better get to your dentist. You have a broken tooth. You can see this has been endodontically treated. This is just broken, but thankfully that was not decayed. But after 10 years, a lot of calculus on the roots, as you can see, between those molars. Bled very easily. And there's the root anatomy, so there is a root proximity problem. So addressing this area and trying to fix it so it stays fixed, that's the intent. And what can we do with minimal surgery? There's also a financial concern here, because being unemployed because of her illness, funds are not readily available. So as I said, treatment needs to be as least invasive as possible, in addition to the financial concerns. I did not want to raise a flap. I didn't want to try to involve damaging the periosteum. So what I did was cut down most of that tooth, right down to the gum line, and I thought in that manner I can reduce the amount of food that was getting stuck in between those teeth. Placed an amalgam in the occlusal decay that she had there, then flooded the area after I scraped it as best as I could with local anesthetic. I placed Silver Diammine Fluoride and Prevora, and that's how it came back in a week. And this amazed me. Like I took this picture because typically I'm very skeptical. When Howie told me, use these products, I thought, yeah, sure. I couldn't believe the results I was getting. So I needed to convince myself, and photographs like this convince me, and I hope it convinces you too. Because now I have the ability to offer something very simple, yet highly efficacious. It works. Just retreat it again. Not very expensive. Same patient, a different area, lingual of the second bicuspid. She had some discomfort, and there was a pocket, 5 to 6 millimeters, and bled quite easily. Applied Silver Diammine Fluoride and Prevora, and that's how it came back after 1 week. No surgery. So we have an isolated deep pocket with bleeding on probing, and those were reduced 1 week later. So a reduction of pocket depth and bleeding on probing is the standard by which we judge the efficacy of treatment. So I've gotten down to less than just a hair under 3 with no bleeding, just painting something on the gums. Unfortunately, my daughter also had breast cancer, as well as being on Zometa. So it warms my heart to know that should there be a problem, there's something for her to try to avoid surgical procedures if it does come to that. Another class of patient that I've been using it on are those with immune dysregulation. And in this case, this patient, female, has been with me since 2000, suffers from lichen planus. As you can see, tissue's red in these areas. Early on, I did send her to an oral pathologist. At that time, used steroid ointment on gauze pads. The ointment's put on the gauze is put in the mouth, and they sit there with it with the gauze hanging out and told not to swallow because you don't want to swallow the steroid. And it's a bit of a messy arrangement. So the lichen planus varies in intensity. Sometimes it's better than other times. Sometimes it can be erosive, quite painful. Other times it's just surface, just not bothering you, but you know it's there. Also, I've tried the magic mouth rinse, which is mycostatin, Benadryl, and hydrocortisone, anywhere from 2 to 4%, with varying degrees of success. But again, that is a compliance issue. So she came in, and again, using my little interproximal brushes, cleaned in between the teeth, and it just bled. Bled a lot with any manipulation. So I put on Prevora. There was no need for Silver Diammine Fluoride in this case. This is just Prevora. And a week later, tissue came back a lot tighter than it was initially. This is the lower right side. You can see the little white striations, indicative of lichen planus. And here, just brushing, the skin just like opening up a faucet with blood. And a week later, skin is tight and did not bleed. First quadrant, same patient, a week later. So please note that I'm not claiming that I can cure lichen planus. This isn't a cure for lichen planus. It's what I surmise that what I'm doing is reducing the bacterial load, reducing the inflammatory response due to an abundance of plaque. So that will help dampen down the inflammatory reaction, and the tissue went on to become more comfortable. So again, I'm not stating this is a cure. Please understand that. And if the patient says I'm more comfortable, with a simple application, this takes all of 10 minutes. With a simple application, they don't have to do anything at home. Just don't brush for a day or two until that film dissipates. I think this is a wonderful treatment. This is another individual, defect over that tooth, went on to do connective tissue grafting, and that's how it healed. And she came back. Not only this area was inflamed, but generally throughout the mouth, all the tissue was red and angry. And this is due, we found out later, we didn't know going in, to some undiagnosed immune dysregulation. We're still not sure what the problem is. I applied Prevora, and that's how it healed after a week. Again, no steroids, just reducing the bacterial load. It could be that her gums got sore, just stop brushing. More plaque accumulated. But applying this led to a very nice result. Initially, when she came to me, before I knew about the immune dysregulation, did use steroid ointment on that and got a nice little healing situation going. However, topical steroids throughout the entire oral cavity, as I said, is messy and difficult. And I'm not comfortable in prescribing oral steroids. It's above the pay grade, as they say. And then the final class of patient that I've been using this in is my elderly patients. I've been in practice a long time. A lot of these people have been with me my entire career. And now they're all on medications, polypharmacy, where a lot of them have dry mouth. And a lot of them are getting decay problems. And a lot of them are getting decay around crowns that I'd put in a lifetime ago. So this is my aunt in 1970. She was on vacation somewhere in Mexico, and she was getting a hug from a staff pirate. But I had noticed even before I was a dentist, but particularly when I was in dental school, I said, boy, she has a dark lateral. Wonder what's going on with that tooth. When she first came to see me in 1982, she had a mouthful of amalgam restorations, but an intact dentition. And here you can see the large composite resin or resin restorations that were in place back in 1982. But that tooth, that lateral, has a unique story. She claims that back in Poland, when she was a young teenager, the tooth became infected, and she had endodontic treatment carried out, which consisted of her getting a shot of booze, and then a wire was passed through a hot flame and inserted into the tooth. And she claimed that the pain she felt in that instant was anything worse than she's ever felt in her entire life. And she did live through the concentration camps. So that's quite a story. And in 1989, had to redo the endo. I believe she broke the tooth at that time. You can see there's very little left, so she probably broke that tooth. And I told her, you need a crown. And she was resistant to the idea because she was told by a dentist, maybe the dentist with the hot wire, don't have crowns because they won't last and your teeth will break. So she was resistant to crowns. But I told her there's nothing else I can do. She asks me, how long will they last? And I said, after I've been doing these for near 10 years, I got a really good track record, hopefully the rest of your life. So, okay, let's do it. This is my aunt in 2020. I showed these two pictures to my cousin. I said, I think she's shrinking. And my cousin said, no, it's just that the pirate is short and the dentist is tall. So in 2020, she was 95 years old, and she was amazing. Physically, she was good. Mentally, she was spot on. And she prided herself on having a full complement of natural teeth, or near full. As many of her cohort of immigrants that came, very few of them had a dentition that is still surviving. And she was very diligent with her oral hygiene. And here is her dentition. I'll tell you that the crown was placed in 1989, that lateral in 91, the two centrals in 93, 3-unit bridge in 98, and these were done by my first lab technician, Gabriel Pintos, and these were done by Dennis DeMarchi once Gabriel retired in 2004. And there's the radiograph. So back at that appointment in 2020, I noticed there was a deep pocket here, and it was just the tissue had a bluish cast to it. So I raised a flap. Whatever was there, I cleaned off and stitched it up, and that went on to heal. There you can see just the puncture wounds of the silk, but that did go on to heal quite nicely. And here are the teeth that the crowns that I've put in. I had to lose the molar many, many years ago, so this tooth did over-erupt. But these crowns have been giving service for 20 to 30 years, and some of them near 40. That filling was placed by me in 83. It cracked, put another one in. Yes, I know there's little chips of porcelain missing here, but these crowns have been in their mouth for 30 years. That's the upper arch. She came back 4 years later, 2024, and my aunt was starting to show signs of physiological and cognitive slowing and decline. I could just tell. And her gums now, which were always pink and tight, were no longer pink and tight, just generalized redness and bleeding. You can see the margins here are just red and bleeding. So I said, I have something for you. And talk about being personally invested in a case. This is my aunt. I mean, she was in the room when I was born. So boy, am I invested in this case. So I said, I have something for you, and put on some Prevora. And she came back a week later, and the tissue tightened up dramatically. Put on another application, and then she got ill, and I didn't see her till June. And here you can see, even with an abundance of plaque that hasn't been cleaned off, the tissue looked pretty good. It was under control. Put on Prevora again. So sadly, my aunt passed away about a month or so ago. She was 3 or 4 months shy of her 100th birthday. So I fulfilled my promise to her, crowns lasting a lifetime. And this is no small thing. Long-lasting success for our restorations require a commitment to excellence that borders on compulsive obsession. And that's what I ask from myself, and that's also what I seek from the clinicians and academics that guide me, and of course from my dental technologists. So you might say, well, you know, those crowns don't look so good now. Well, I'll tell you, I don't look so good now either, because that's how I looked about 30 years ago. When I went out for Christmas dinner with my lab technician. We did this every year, Gabriel Pintos. And Gabriel and his wife Carolyn composed a lab of 2 people. So for the first 24 years of my career, Gabriel and Carolyn did all the crowns, just 2 sets of hands. So they are my partners dedicated to excellence. And that's Dennis DeMarchi. Sadly, Dennis passed away also some 4 years ago. Ran Prism Dental, and that's been taken over by another fastidious gentleman who also gives me a lot of attention to detail, and that's Davor Medunik. He's now the owner of Prism Dental. Our myths are powerful and often stubborn. My experience with this brave lady has taught this old dog new tricks. that it's not a binary choice, but rather an opportunity to use both surgery and non-surgery to achieve efficacious results and treatment. So often you need both. A combined approach is based in science. Obviously, you have to do surgery to remove deep calculus and debris and address bone defects and such. However, the modulation of the host response with a simple non-invasive protocol is equally as valuable, particularly in cancer patients or those immunocompromised that can't undergo extensive surgery. Used in combination, I have something to offer cancer patients that is efficacious, easy, and cost-effective. Before this, I had little else. Of equal importance is their use in patients suffering cognitive and physical decline, to the point where personal oral hygiene is no longer sufficient. Fortunately, my aunt provided a successful clinical case, and by comparison, hers is a benign example. There are far more dire cases where seemingly nothing can be done. I have a colleague, she's an independent dental hygienist, and she sends me photos of cases that she sees asking my advice, and these are off of her cell phone. Like, what to do? What do I do? I will tell you that this dentition belongs to a retired orthopedic surgeon who spared no expense to take care of his teeth with sophisticated dentistry. Sadly, dementia has taken its toll. Studies have been done demonstrating the benefits of non-invasive therapies in cases such as this. The problem is the delivery of service from a physical perspective. I mean, it's hard to do this when you're in their suite. They may be in a bed, a wheelchair, they may be on a couch. So it's difficult, and you don't have suction, you don't have air supply. It's hard to do it, but it can be done. And also, you're maybe dealing with folks that are just uncooperative due to their mental decline. So one wonders if this dentition might have been saved with the regular application of high concentration of chlorhexidine in conjunction with SDF, Silver Diammine Fluoride. The last slide is of Hippocrates. He's the philosophical father of healthcare. There are three pillars for healthcare as far as I'm concerned. First, there's the science. And that's what we get in textbooks, the knowledge we find in peer-reviewed literature and accredited lectures. Sadly, we're inundated with misinformation from unscrupulous academics, manufacturers, and self-anointed gurus. Now, please note, I'm not setting myself up as a guru. I'm a hardworking dentist working full-time. I have a lot of clinical experience, and what I'm trying to do is just share that with like-minded individuals. Then there's the art of dentistry, and that's how well do we perform our surgery? Do we get all the calculus off? When we're preparing teeth, do we sculpt them to a particular dimension that's ideal and acceptable? Do we get our impressions that are near perfect or perfect? Do our lab technicians perform their artistry casting metal and firing porcelain so that we can manufacture, design, and present, in this case, 2 splinted crowns that will last the patient's life? And that's the patient that's undergoing multiple myeloma. So everything is important. Fine margins, good lab. There's no room for error in dentistry. And finally, there's the humanity, often not talked about. And the humanity is how willing are we to throw ourselves at a problem and go beyond the normal everyday activity. It's the measure of the compassion we feel and express while undertaking the art and science of our craft. And I think this presentation and the other 20 some odd that I have on YouTube will help give you some insight as to where I fall on that spectrum. And with that, I look forward to the next presentation. Thanks for listening. Bye-bye.